At the University of Manitoba. She's medical director of the hemostasis laboratory at the Winnipeg Health Sciences Center, co-director of the Manitoba Pediatric Bleeding Disorders Program, and senior scientist in the Research Institute in Oncology and Hematology at Cancer Care Manitoba. She also does a lot, she wears a lot of other hats, but I'm not going to go into those today. But just to say that her clinical and research interests include acquired and congenital hemostatic disorders in children, and platelet function and dysfunction. And it's on, that's what she'll be speaking about with this primer today, on platelet function and dysfunction as it relates to women and bleeding disorders. So I'm going to hand it over to Sarah.
I think he just gave you ladies both a standing ovation.
Yes.
Thank you very much. I was asked at the time that I was assigned this talk to provide a primer. Now I realized when I looked around the audience this morning to see who would come to this, that probably primer is too primary for you. So I am going to give my talk, but I'm going to try and raise it, and I'll be happy to answer any questions. And I will probably be reiterating some things that Dr. Garvey said this morning in her session. So shall we get started? We're going to start with a case. This is a 16-year-old girl who presents with heavy menstrual bleeding to her family physician. She's had heavy menstrual bleeding since puberty. And she also has a history of easy bruising and frequent but brief epistaxis. She's on no medications. You can see her blood counts there. Her hemoglobin is 95, her MCV is a little low, and her ferritin is 7. So does this patient have a bleeding disorder? Yes. Hands? No? We don't know. We don't know. Next question. If this patient has a bleeding disorder, what do you think is more likely? A, von Willebrand's disease, B, platelet function disorder, C, something else, D, not enough information to say. Okay. So I want to focus on primary hemostatic defects, and in a minute I will explain to you what a primary hemostatic defect is. But it is really the kinds of things that you think about as related to mucocutaneous bleeding. And there is obviously a list of kinds of things that patients who present with mucocutaneous bleeding have trouble with. And women, of course, have the added issue of heavy menstrual bleeding and postpartum hemorrhage, which explain why women with this constellation of mucocutaneous bleeding show up in clinics more often than men. But actually, I don't think I can tell the difference between somebody who has von Willebrand's disease and somebody who has a platelet abnormality if there's no family history with a diagnosis, and we haven't done any laboratory testing yet. Because the presentation in terms of clinical presentation can be very similar. So this is just to remind you that platelets actually are the children of megakaryocytes. Megakaryocytes are the big cells in the marrow that go through a very dynamic dance to produce proplatelets that are released into the circulation. And so for any inherited platelet problem, the defect is actually in the megakaryocyte. And they pass on, or don't pass on, certain organelles or defects to the anucleate platelet. This is a transmission electron micrograph of a platelet. And so it all really starts with the megakaryocyte, even though what we're doing is measuring the defect in the platelet. So this is what you need for hemostasis. You need a healthy blood vessel, and by that obviously I mean it's been damaged, but what's underneath those endothelial cells has to be there. You need platelets, you need the right number, they need to be working, and then ultimately you need the clotting factors to assemble that fibrin mesh on top of the primary plug. So here are the platelets streaming near the endothelium. The vessel wall is damaged and the platelets adhere to proteins in the extracellular space sitting below the endothelium, and then you get this primary plug formed. Then, on top of this, is where the fibrin mesh forms to hold it all in place. Okay. So this is a cartoon from a review that Margaret and I wrote a few years ago that sort of digs down into all of the things that happen when that platelet shows up at the damaged site. So here is the collagen that has been exposed, and bound to it is von Willebrand factor, so there is von Willebrand factor sitting there. And the platelet that arrives at the surface actually isn't activated yet. It's resting. It gets captured by the collagen or by the von Willebrand factor based on collagen receptors or von Willebrand factor receptors. And once that happens, that stimulates a whole signal transduction train inside the platelet, which results in a whole bunch of things happening to that platelet. The platelet changes its shape, it spreads out to cover the area of damage, it starts to make substances that it releases that recruit other platelets, such as thromboxane. It releases at least two types of granules that have prothrombotic proteins, clotting factors, and other substances, including von Willebrand factor and factor VIII. Or substances that recruit and activate other platelets from other kinds of granules. It changes the surface of the platelet, so it now provides a platform for the clotting factors to assemble, which then create thrombin generation and then fibrin formation. And finally, it activates these receptors, alpha-2b beta-3, sometimes called glycoprotein 2b3a, the fibrinogen receptor, which binds, and it's the cross-linker that results in platelet aggregation. So when you think about all that, you can think of all the places where something could go wrong to cause a platelet defect. There could be something wrong here, something wrong in the activation, something wrong in the release of these substances, something wrong in the platelet binding. And so here is another cartoon from another review that Margaret and I wrote, that's all we do, and which gives you some idea for all of these various functions of the platelet, the diseases that have been described, the inherited platelet diseases that have been described, where abnormalities in those functions have been identified. And this isn't all of them, and I'm sure there are ones that we haven't identified or labeled, at least yet, and don't understand. But as you can see, there are many, many things that can be wrong with a platelet. And that's what makes diagnosing platelet disorders so difficult. This is not one disease, and it's not even a couple of diseases. It's many diseases. It's a whole long list, and of course, they're not all the same. And because the defects are different, how they present in the laboratory looks different, even if how they present in the patient in terms of bleeding isn't all that different. The other thing is you can't even think of them as easily low platelet counts here, so thrombocytopenia here, function defects here, because in fact there's an overlap. Some of these inherited abnormalities have both an issue with number and function. The other thing is that there's a whole pyramid of severity from types of platelet disorders that cause severe life-threatening bleeding down to ones that are extremely mild and may not cause people a lot of trouble from day to day. And in fact, the most severe ones are very rare, and the mild ones are relatively common. Next. And the inverse is true of how easy it is to diagnose them. So it's relatively easy, to diagnose the severe ones because they have a very typical phenotype in the lab. And the common ones can be almost impossible to diagnose depending on your access to testing. So we have this sort of yin-yang, which makes it even more difficult to get to an answer. So how common are platelet function disorders? The answer is we don't actually know how common they are in the population because we've never had any population studies to tell us. And that's probably for all the reasons we've already just said. People's access to testing, how comprehensive our testing is, because of the number of different disorders there are, and how well standardized it is, as Dr. Garvey mentioned this morning, not easy to standardize. So we have no population prevalence data. We do have registry data. So here's numbers from the UK registry and from the Canadian registry. And although the total numbers differ, you will see the ratio of people in the registry with von Willebrand's disease to platelet function disorders is almost exactly the same. It's almost 5 to 1. It doesn't mean that von Willebrand's disease is 5 times as likely to occur as a platelet function defect. We actually have no idea. That is how they've presented to clinics, which means that's how they've ended up in the registry. Margaret was able to provide me with a little bit more detail about the platelet disorders that are in the Canadian registry, and you'll see that it's a whole list. Up at the top are some rare but very well-defined platelet disorders, and as you go down, you will see things are less well-defined until we get to more than half of them which say undefined platelet function disorder, which means that somebody tested a patient with mucocutaneous bleeding symptoms in their lab and found an abnormality but didn't have a label to put on it. And that's more than half. The other thing that you see here will not be a surprise to you, and that is that in most of these cases, more than half of the patients are women, because they're presenting to clinics more frequently than men, and therefore they're being tested. And there's a whole bunch of stuff about how people have tried to figure out more specifically what some of these are, but the biggest category remains undefined for us at the moment. Next. So what do we know about heavy menstrual bleeding and platelet disorders? And I think considering it's 2018, not as much as you would think. The number of studies that have looked very specifically at platelet function testing in women who have presented, or teenage girls who have presented with heavy menstrual bleeding, is relatively small. And there are more than 3, but I've pulled out 3 as examples. And you'll see that in these studies, which were not terribly large, 50 to 60% of patients were found to have some abnormality in their platelet function testing, usually aggregation assays or a secretion assay. But none of these studies used exactly the same testing algorithm or the same way of looking at platelet aggregation or the same way of interpreting results, because we all do that a bit idiosyncratically despite the guidelines that are now out there. And so you can see that these aggregation abnormalities are not uncommon, but the connection with these women's heavy menstrual bleeding is not clear. The bottom point really is to say that in the end, clinical data, including bleeding from menarche, which I always think is a very important clinical parameter, may be more important, and I think that everybody should be using some kind of bleeding assessment tool or questionnaire to get at the severity of bleeding before they send the patient to the lab. So what can labs do? So labs, almost every lab can do a CBC and a platelet count for you. Most of us have access to that. MPV is mean platelet volume, which is an automated assessment of how big the platelets are. And all of that is very helpful, but I still find that I personally like to go to the lab and look at the platelets myself to see what they look like, to see how big they are, to see whether they have granules or not. So here's a platelet that doesn't have granules, and it's a patient with gray platelet syndrome. Here's a giant platelet. One of my residents recently thought it was a lymphocyte. And here's a patient with MYH9 related disorder that has doughy-like bodies in the neutrophils. So there are things you can learn just from a smear if you go and look. Next. The next thing that most labs have available to them in tertiary care centers is aggregation. We use light transmission aggregation, where you've taken the red cells off and are looking at platelets in plasma, but there's also whole blood aggregation where you don't take the red cells off and you just look at platelet aggregation in the whole blood setting. So this is where you put the platelets in plasma in little tubes. You throw in soluble agonists or stimulators that will make the platelets aggregate in the tube, and then you can measure that. And we all have reference intervals and standard menus of these stimulators that we use. And you get actually a very nice curve where you can see the change in the platelet shape, because they go from little plates to they round up as the first step in this in vitro system, and then they clump and you get this curve. And that's great. And it's a very old system. It's been used since the 1960s. The inventor just died a few months ago. And it has been used, I mean, it was the way that we identified very severe platelet function abnormalities initially, but it's fraught with technical problems in terms of standardization. So you really have to have a lab that does lots of these in order to get some reasonable results. So then there are a whole bunch of other tests that we can do looking at platelet morphology, function, secretion, and eventually genetic testing, but it's quite variable how much access we all have to any or all of these tests. Some of us in this room may have access to all of them. Most of us have access to some combination, and we tend to use what we have. And the result of using what we have is that you find what you can look for. So I can do electron microscopy in my lab, so we look at lots of platelets, but that's not something that other people can do. I don't have very good access to flow cytometry, which is something that other people have more access to. So it's quite variable, and it impacts our ability to diagnose. So now I'm just going to give you a couple of examples of how we can use the lab to make a diagnosis. And the first one is Glanzmann thrombasthenia. Glanzmann thrombasthenia is a very severe and very rare platelet function defect. Its prevalence is supposed to be about 1 in a million people. I live in Manitoba, where there are 1.3 million people, and I know we have 2 Glanzmann thrombasthenia patients, and I don't think there are any more out there. Anyway, these people have severe bleeding, and women in particular have very severe problems with heavy menstrual bleeding, right from menarche, and in fact this can be life-threatening. And the reason is because this receptor that I showed you, this alpha-2b beta-3, is either absent or defective in people, and so they can't aggregate their platelets at all. Doesn't mean the platelets don't get activated. They may very well get activated, but they can't clump, so they can't form that primary plug, and bleeding is very significant. And because they can't clump, when you look at them in the aggregometer, they don't clump, so you get no aggregation at all. The blue is the normal curve, and the red is a patient with Glanzmann thrombasthenia. So they don't respond to any of the agonists in terms of a measure of clumping. And we now know, and have known for quite some time, that there is a defect in this receptor, next. And you can see this very beautifully if you have access to flow cytometry. So this was done by Margaret, and we've put this into a recent review. So here is a different receptor that is measured as a control. So you can see that the patient who's in blue and the normal in red have almost the same level of receptor on the surface of their platelets. Well, this antigen, which sits on that receptor, is significantly lower in the patient with Glanzmann's thrombasthenia. So if you have access to this assay, this is a slam dunk. This is Glanzmann's thrombasthenia, it's not anything else. So this is for sure. You could then go on and do genetic testing so that you can find a very specific mutation that has caused Glanzmann's in this patient, which may be very useful. But this gives you the diagnosis. Not very common, however. Next. So now I'm going to tell you about a much more common abnormality that we see fairly frequently in our lab. It's not all that unusual, and that's a secretion defect. So this is where The granules that contain those substances that help to recruit other platelets don't release their substances when you activate the platelets, and so you don't get recruitment. And so you get partial aggregation. So you will see an initial aggregation with some of the stimulators, but it doesn't go all the way up. It can't recruit more platelets to the clump, and so it dissipates. So you get some aggregation, but not full aggregation, or with some things you'll get aggregation and then the clump will fall apart. However, not all secretion defects have this really nice aggregation pattern. As a matter of fact, some patients with secretion defects have almost normal aggregation. So it's not a rate. If it's there, it's helpful. If it's not there, it's not very helpful. So we have another aggregometer in our lab, which can actually measure bioluminescence. It can actually measure substances that are released from the granules, in this case, ATP. And so that you can actually see whether the platelets are secreting or not. So here, this is the aggregation curves up top, and these are the secretion curves. This is a normal, where you can see the amount of ATP come out of the platelet after you've stimulated it. And this is a patient where no secretion is happening. So it can be helpful if your aggregation curves are sort of not very clear. If you see this, you know the patient has a secretion defect. Well, then there's still two possibilities. Either you don't have any granules, so there's nothing to release, or you've got granules, but there's some problem and they won't release. And so to try and sort that out, we do electron microscopy. This is whole mount electron microscopy, where you can just drop the platelets on an electron grid, and you don't have to do anything else to them. And these dense granules in the platelets are very inherently electron dense, so you can just count them. They look like little balls sitting in the platelets. You know that this patient has granules, so it must be some defect in the release of the granules. Now that could be anything. We don't even understand all the possible abnormalities that could lead to a secretion defect, but at least you know it's not a granule defect. This is not the only way to measure granules. You can also do it by flow cytometry. You can do it by some other methodology, but because I have an electron microscope, I do it this way, but other labs do it other ways. Okay, next. Genetic testing. The role of genetic testing is changing very, very rapidly. So if you had asked me 10 years ago, I would say, well, you know, if you think you've got Glanzmann thrombasthenia, sure, but what else are you going to test for? Now that we have identified over the last decade and increasingly rapidly identifying new genes that we know are involved in platelet function defects and in thrombocytopenias, the list for possible testing is much longer than it used to be. And is very helpful in terms of identifying all of those patients where you do all the functional testing you have available and you still don't have an answer. So after you've done all the functional testing, you may still have only labeled 40% of the patients who you're worried about. And genetic testing will not identify them all, but more and more every year. And so here is the same cartoon again, now with all these defects and some of the genes that have been identified that are involved in these defects. So the mutations in these genes are related to these defects. This gets added to every year. This is not them all. These are just examples that I've given you. And if you like to read about platelets, you can open a journal every month and find out that somebody's identified a new gene. So it's actually very exciting. And as people develop panels for testing thrombocytopenias and function defects, it is possible to send your patient samples off and have this done. But should you do it for everybody? So the question is, who should you do it for in 2018? So I'm very pragmatic about this. I think that if you have a research program and want to know what everybody's mutation are, you're going to approach this differently. But if from a pragmatic standpoint of clinical diagnosis, the patients it is most helpful for is those who have a very well-characterized abnormality. So if you have somebody who in your lab looks like they've got Glanzmann thrombasthenia, you could send them off to have those genes tested and you will probably get an answer. Or if you have a patient where their platelet abnormality is part of a syndrome that involves other things that is well described, that can also be very helpful. Or if you have a very large pedigree, even if you don't know what it is, if you have multiple people with a phenotype, your geneticist may be very interested in helping you try to sort out where the mutation is in that family. And we've done that for a number of large kindreds in Manitoba, and that's actually very exciting when you find something. But those are the minority of all of the patients that you're going to see. Then there's everybody else. And I think that still in 2018, everybody else is probably not ready yet to have genetic testing done. We don't know yet what we're looking for. I may be giving a different talk in a couple of years because the technology is there, but how we use it is still a little bit behind that. The other thing is that we now know that there's huge variation in things that we consider to be normal. So what they've done is they've done a very large genome-wide association studies with things that we think of as very simple, platelet counts, platelet size, and has found genes that we would never have suspected were associated with characteristics of platelets that are associated with variations within the normal range. And so this is even more complex, of course, than we thought by measuring platelets from a functional standpoint. And so all these little single nucleotide variants in genes that we have only discovered because of this new technology are starting to inform how we understand platelet function. And by that I mean normal platelet function. They may eventually help us to figure out platelet abnormalities that we don't actually have a label for yet. So unfortunately, this is the least I have to say. You've heard some wonderful talks today about managing women with heavy menstrual bleeding and postpartum hemorrhage. And unfortunately, or fortunately, for most women who have a platelet function disorder, you're not going to do anything a whole lot different than what you're going to do for patients with other bleeding disorders. You need a multidisciplinary team with obstetricians and hematologists and sometimes geneticists and neonatologists. That doesn't change. I agree with a number of the comments that were made earlier today about the importance of treating anemia. It is absolutely true that people with anemia bleed more than people without anemia, no matter what their platelet or what function defect is, or Willebrand's disease, or even if they have none of those. Anemic people will bleed more, and you can improve their bleeding by improving their anemia. Other choices related to managing heavy menstrual bleeding are not a whole lot different than what you've heard from other people talking about other bleeding disorders. And there are very few exceptions, except for perhaps the most severe and rare platelet disorders, where in fact even these may not be adequate under certain circumstances. Dr. Poon, who was here in the last session, was very involved in identifying that recombinant factor 7A can be a useful adjunct to other treatment for women with Glanzmann thrombasthenia who have not responded to other therapies. And sometimes when your back is against the wall, we give platelet transfusions. And it's not that platelet transfusions aren't helpful, they're very helpful, but we try to reserve them until we really need them because of risks of alloimmunization, that they may not then be available when we really need them. But there are certainly circumstances where that's a necessity. I just want to briefly say something about acquired platelet function disorders. Acquired platelet function disorders are, of course, far more common than inherited platelet disorders. Every man over the age of 50 is supposed to be taking aspirin every day as primary prevention for cardiovascular disease, which means they've all got a platelet disorder because we've inhibited COX-1 in their platelets. They're not making thromboxane, and so their platelets don't work as well as if they weren't taking aspirin every day. So that's very common. But lots of women take various non-steroidal anti-inflammatories for naturally occurring prostaglandin or antiprostaglandins as part of management for dysmenorrhea. And I wouldn't say that they shouldn't take them, but you need to know that they're taking them before you send them to the lab, because they will impact our platelet function testing. So these are just some resources that are available on the HCDC website. This is an algorithm that Margaret and I made a few years ago. Next. This is diagnostic criteria for inherited platelet disorders. And finally, these are some booklets for patients and families about platelet function disorders. And all of these are downloadable from the HCDC website. And finally, a few take-home messages. Don't forget about platelet disorders when you see young women with bleeding. People are getting very good about thinking about von Willebrand's disease, but please think about platelet disorders as well. Bleeding associated with platelet disorders can go from anything from extremely severe to very mild, so you have to think about along that whole spectrum. Screening tests are not terribly good. I actually think a bleeding assessment tool is probably better. And then eventually, if you think you have somebody with a significant primary hemostatic defect, you're probably going to have to send them to a specialized laboratory for quality platelet testing. Thank you.